Hi, Phil. Hi, Raj. Hello, Zakaria. See if you put your name in the chat, you get a special cheer from me. It's a bonus. Hi, Bailey. Hello, Astrid, Sujay. So many friends today. Hi, Tamsin. Hi, Wizal. Antonio. ¿Cómo estás? Hi, Paul. Hi, Bushra. Hi, Syed. Hi, Bernice. Okay, I think we are going to start slowly. People are kind of used to the brilliant GNC webinar. We'll try to be up to the standard. So we'll do a bit of introduction, but many people are familiar with it. So thanks a lot for joining us for this webinar on Lesson Learned from the Accelerated National Review of IMAM Guidelines. We have translation available for this webinar. The translation is only in English and French. Apologies for other colleagues. So as usual, to be able to access the translation, you have at the bottom of your screen a little button with a little globe for your interpretation. You can have it off if you speak both language, or keep it in English or in French. And actually, we will have two presenters speaking in English and one in French, and we'll be alternating a little bit. So you will, if you speak only one of the language, you will need to use a translation. So we are here today to talk about revision of national guidelines and learning from examples from three great countries. And hopefully they will help all of us to understand a little bit more the process of the revision of national guideline. They will help us to have a better understanding of the technical content of the updated guideline as well, because you'll see that it's quite rich in terms of the details that they bring to some of the recommendations. Very interesting. I've seen the slide and I'm really, really looking forward to hear what is there to say. We'll talk also about the management of wasting during special circumstances, because those national guidelines included a part on it. And then we'll understand a little bit some of the challenges and the mitigating measures that were put, and particularly about the rollout, because writing a guideline is one thing, but implementing it is another one. So after this introduction, we will have some presentations and answers from Nepal, Uganda, and Mauritania. And so you will see, I will be asking them questions and they will be answering me, sometimes with slides, sometimes without. And they will all be answering the same sets of answers. And then if I manage the time well, wish me luck, because we have a lot to say. We will have enough time for questions and answers at the end, and then we'll be closing. So who is there with us today? So we have first Mr. 𝗃𝗵𝗀𝗃, who is the chief of the nutrition section of the Ministry of Health and Population of Nepal. Then we have Mr. 𝗃𝗵𝗶𝘀, who is senior nutritionist and national coordinator for IMAM and nutrition in emergency at the Ministry of Health of Uganda. We have Dr. 𝗃𝗵𝗃𝗀𝗃 with a lot of title, with associate professor and former head of pediatrics and child health department at Makerere University in Uganda. And then we have Dr. Mokhtar Abad, chef du service de développement de la nutrition au ministère de la Santé en Mauritanie, et Monsieur 𝗂𝗵𝗶𝘀𝗶, qui est coordinateur nutrition santé pour Action contre la faim Mauritanie. Then, to bring a little bit of feminine energy to this panel, your very own. I'm going to try to make it as lively as possible. And then in the background, but very importantly, helping me is also 𝗷𝗂𝗀𝗏𝗔𝗂 IMAM, who is a Senior Technical Advisor for Health and Nutrition for Action Against Hunger US. Thanks a lot, 𝗷𝗂𝗀𝗏, and thanks a lot in advance to all our expert panelists already for the content of the material that they submitted. So as I mentioned, we will be learning today from Nepal, Uganda, and Mauritania. So, Mr. Lila, can you tell us a little bit first about the context of malnutrition of Nepal and the process you've been through with the revision of the guidelines?
Thank you, Alexandra. In the context of Nepal, wasting has been in Nepal. Wasting has been stagnant from the 25 years. In past 5 years, 10% in 2016 and 8% in 2022 National Demographic Health Survey. Stunting has been reduced with huge investment from the 41% in 2016 to 25% in 2022. IMAM has scaled up from the piloting in 2008 and has nationwide coverage now. And the government of Nepal has taken up and owned this program as priority 1 program in Nepal.
Thank you very much. So, can you tell us just a little bit the process you went through for the revision of your guideline in terms of the type of meeting, the committee that you had in place, and are your guidelines now finalized and validated?
Yes. In regards to the development of the guideline, we sit together with ACF Nepal, UNICEF, and other external development partners, and then we decided we see the difference of the new guideline and our previous guideline in 2020. So we came up the differences, and we decided and we make a kind of minute as a government. We request to ACF Nepal and the UNICEF Nepal to make a updated guideline for the IMAM to implementation of the IMAM program. So in addition to that, the ACF Nepal, they had we will request them to complete the SLIC survey and 𝗂𝗏 survey from some of the district of the Nepal, and then we just and also there was extensive literature review, and also we made a kind of matrix mapping, and then as I already mentioned, the finalized format of guideline from the NUTEC meeting. We do have the nutrition technical committee, and before that, we do have technical working group, and final one is the nutrition technical committee. So from all the evidence, as I earlier mentioned, SLIC, anthropological study, which we found we found the barriers and boosters. So then we just revised the guideline with the consultation of the bilateral, multilateral, and working group and the working group session with the technical committees, and then we draft the guideline and we proceed as our process of the government of Nepal, and we endorse from the 𝘂𝗶𝗃 committee.
Thank you very much. And I remember very well the exercise of coverage survey. It's really good to hear the whole assessment component that was quite thorough in Nepal before beginning the process. So well done on that. Thank you very much. Now I'm gonna ask about the same thing about Uganda. So I don't know if Ezekiel or Tim, you can tell us a little bit first about the burden and then the process.
Sorry. Good evening from here in Uganda. The situation in Uganda is such that the burden of child wasting stands as follows. We experience fairly high burden of undernutrition, and approximately 3% of our children under 5 at any one time have child wasting, meaning they either have both, they have mom or some. And in absolute numbers, that's approximately 268. And this is quite a big number when you look at it in absolute numbers. And yet, approximately 10% of the cases which have severe acute malnutrition in our country access the treatment, meaning that the biggest proportion, even with the presence of our OTC services in place based on our guideline, 90% are not be able to receive this coverage. And but generally, there has been an improvement. When you look at stunting, for example, if you look at the slides of before you, since 2001 up to date, there's been an improvement from, imagine 45% in 2001 up to 26% in 2022. This is based on our Uganda demographic health surveys. And the same applies to other forms of malnutrition, but particularly in wasting. Wasting has been fluctuating between 5 to 3. And as we speak right now, 2.9%, as I said, of the children are wasted. Yet in 2001, we had something to do with 5%. The highest was realized in 2006. 2006, when we had 6% of our children had wasting. So this is the situation of the burden of wasting in our country. And a reflection on the guideline process review, at the time when we saw the revised guidance on the WHO, the Minister of Health reached out to the in-country UN agencies and also looked out for the existing pool of technical experts so that we could avail resources as well as expertise to see how best we could review our guidelines. With the guidelines we have are the 2020 IMAM guidelines, and they were to be reviewed to align with the 2020 WHO recommendations and best practices. So we hit out the groups, and we also we saw an expression of interest announcement, and the Minister of Health, together with Makerere University, we responded to that expression of interest by Elina Krupp Foundation to make sure that we are considered for support, and that was also given to us, and we actually did that. So during the process, we had an inception today stakeholder workshop as the first thing that we did. That meeting helps us to define our needs, our objectives, and the roadmap for the review of the IMAM guideline. And thereafter, a writing team of 5 national IMAM experts and some child health experts was constituted, but with the MOH focal lead and 𝗃𝗏𝗃𝗏, so that this was supposed to undertake the writing of whatever we were making as our changes, and they had clear terms of reference. And then thereafter, we had a series of technical workshops that were conducted. And this was involving, of course, the experts in nutrition and child health. And thereafter, we had regular stakeholder mappings. In other words, stakeholders are quite a number, and at each point there was when we felt specific stakeholders were needed, and we were engaged. They were engaged, and this was through Ministry of Health as a lead. And recall that at this point we had developed the engagement of these people or these partners through our nutrition technical working group. At some point, we had to ensure that the regional UN agencies also had an opportunity to review and give us their input in the development of these revised guidelines. I want also to say at this point that we also had the opportunity of the SCF consultants who prepared some initial drafts when it came to the area of nutrition emergencies and nutrition in special circumstances. So that is just a brief, but there was a lot behind these brief statements. Thank you very much.
Yeah. There are a lot of details that you cannot share here, but it was a very thorough process. I could see that. Thank you very much for this. So now we're going to hear a little bit from Mauritania. So if you don't speak French, please use the translation because we will start talking in French. Donc, on va parler un petit peu de la Mauritanie, du contexte, et puis de ce processus de révision du protocole. Donc, je vous laisse le champ libre.
Merci beaucoup. Salam alaikum wa rahmatullah. Bonjour à tout le monde.
Salam alaikum.
Merci beaucoup de nous avoir donné cette opportunité pour partager l'expérience de la Mauritanie et échanger avec vous et d'écouter les autres collègues de Ouganda et de Népal et des autres pays. Merci beaucoup. Je suis docteur 𝗃𝗶𝗀𝗃𝗏. Je suis le chef de service de la nutrition au ministère de la Santé. Donc, voilà. Je vais vous présenter un petit aperçu sur notre processus de révision du protocole de prévention et de la prise en charge de la malnutrition. Cette fois-ci, nous les avons appelés PCMA, c'est-à-dire protocole de prévention et de prise en charge. Et nous avons essayé d'être le plus inclusif possible en associant les autres entités gouvernementales et d'autres partenaires qui s'occupent de la problématique de la malnutrition dans le pays. Alors, quels sont les facteurs qui sont permanents et qui aggravent la situation en Mauritanie? La première, ce sont des crises récurrentes d'insécurité alimentaire dans le pays. Également, comme vous le savez, peut-être le contexte du changement climatique défavorable, donc le pays subsaharien qui de plus en plus augmente la sécheresse et parfois aussi des catastrophes naturelles, à savoir les inondations, le déplacement de population et tout. Donc la hausse des prix également des aliments. Également alimentaire structurellement fragile par une raison ou une autre, donc d'organisation et de réglementation parfois. Alors, le parcours du protocole de prise en charge de la Mauritanie. le premier protocole était élaboré en 2007. Donc, c'est le protocole de prise en charge de la nutrition aiguë. Ensuite, il a été révisé en 2011 et puis en 2023, nous avons reçu les nouvelles directives donc, de l'OMS. Après donc cela, comme vous le savez, il y avait des avancées scientifiques majeures depuis 2011. Donc, et donc certainement, ceci est le facteur initial et principal de directive de 2023, c'est la prévention et prise en charge de la malnutrition. Donc, il était également question d'intégrer l'approche mesure du périmètre brachial. Donc, euh, voilà, tous ces facteurs-là ont amené la Mauritanie à entamer ce processus. Désolé, je voudrais en parler, un petit rappel sur les données de la Mauritanie. De notre enquête qui vient d'être achevée la semaine dernière, les données de l'enquête SMART. Donc, nous avons organisé le mois dernier et dont résultat global de la malnutrition globale 12,72% et de la malnutrition aiguë sévère 2% et la malnutrition 24,02%. Voilà, donc certains impératifs ont donc poussé la Mauritanie à faire cette revue. Donc voilà, donc cette revue n'est pas une option, mais plutôt c'est une nécessité, donc impératif pour inverser la tendance et sauver des vies. Ce nouveau protocole est le pierre angulaire de notre réponse renouvelée et intégrée de la malnutrition. Nous avons un dispositif multisectoriel. Donc, ce dispositif nous amène à avoir un document stratégique pour la coordination des réponses, l'efficacité et également le partage des résultats. Nous avons tout d'abord engagé un processus qui contient l'identification des pilotages qui étaient pilotés par le ministère de la Santé et grâce également de ses partenaires. La coordination, nous avons mis en place un comité technique multisectoriel et multipartenaire aussi multipartite. Donc, nous avons essayé d'être, comme j'ai cité au début, d'être le plus inclusif possible. Nous avons inclus toutes les parties prenantes pour pouvoir en sortir avec un document consensuel qui prend en compte la partie prévention, mais également la partie prise en charge. Nous avons d'améliorer la couverture, l'efficacité et l'impact de l'intervention nutritionnelle pour les enfants de la Mauritanie. Voilà, donc nous avons plusieurs phases pour arriver à la revue et un document pour la Mauritanie. La première phase, c'était la mobilisation et la préparation qui a coûté presque un trimestre, donc entre le janvier et le mars 2024. Et puis, nous avons ensuite la phase de structuration et lancement opérationnel. Donc, c'est suivi bien sûr, la Mauritanie a suivi cette structuration et lancement opérationnel. Et puis, la phase de révision technique, la Mauritanie a adopté cette phase entre le mois de décembre et le mois de février 2025. Et la validation officielle a eu lieu le mois d'août passé et nous avons ensuite entamé le processus de mise à l'échelle et de mise en œuvre donc de formation d'un pôle de formateurs national grâce à l'appui de l'OMS et des autres partenaires. Et nous avons commencé donc la dissémination de ce protocole en faisant des ateliers de formation au profit de prestataires de prise en charge et également de prévention au niveau décentralisé du ministère de la Santé et les autres entités gouvernementales qui s'occupent de la prévention et de la prise en charge avec nous.
Merci beaucoup. Merci beaucoup à vous. Je vais repasser en anglais. I'm going to switch back in English, doing it slowly because we have only one translator and she needs to be able to switch. Just to say that you can see very well from those three presentations, it's not a short process to review a guideline. It takes long if you want to do it properly, from assessing the situation and going through different revisions and making sure that it's really being endorsed by everyone. So I think it's the first thing. This is not a short process. Like, remember that if you have to start it for your country. Speaking about that, we are a little bit curious about who we have on the call, and if you, wherever you are based right now, where the national guidelines on management of acute malnutrition reviewed in the country where you work, or if you are, let's say, in another country, but you are working for another country, and let's say you're working in Europe or in the US and you support another country, well, pick all the countries and make the median of it. So go on menti.com, use the code that you see, or use a QR code, and tell us if the national guidelines were reviewed in your country of intervention or not. Let us know, and I'm going to switch to seeing your answers. And if you didn't have the time to do it, I'm going to share back the code. Yes, you'll be able to see the code again. In here. It's coming back. So you have the code here and the QR code if you haven't been able to answer. So how many people voted so far? As more people are voting, it is switching. It's good to see that we don't see any no, so at least it's in process. If there was a no, I would have liked to know the name of the country, so that's all good. Okay, if you're continuing voting, that's okay, because I can still see the answers later, so no worries. I'm gonna go back on the slides, and we are gonna continue in English with our participants, and I'm gonna go back to Nepal. So we have a question to all our panel, and the first question is, when the WHO guidelines came out, what were really the priority areas that you estimated would allow you to better respond to wasting in your own context, in your own country, and why? So we'll hear first from Nepal and the priority areas.
Thank you very much for your questions, Alexandra. Within the section of updated national guideline for IMAM that would allow the better wasting response, management of infant under 6 months at risk of poor growth and development included the proper clinical and the nutritional management of under 6 children, as we call IMAMI, which was limited to referring to ITC in the previous guideline. Similarly, detailed post-exit interventions, which included the roles of health workers and volunteers after the under 5 infants and the children who are exit from the outpatient care. So, in addition to that, I would like to highlight here is the updated IMAM guideline of Nepal is very different than the previous ones, as it is a key legal document endorsed by the Director General of Health Services and has direct implications on its implementation mandate. So, as I earlier mentioned, management of infant under 6 IMAMI. In our earlier 2020 national guideline, there was very limited support for under 6 months. Only few criteria was there. That is infant less than 6 months, weighing less than 3 kg referred to ITC. In this guideline, detailed assessment, which are comprehensive assessment, in-depth assessment, follow-up of under 6 month infants are in place. For Nepal, we did conduct the 6 surveys and assessments covering the 3 provinces, SLIC assessment and anthropological survey. The results from these studies were also incorporated in updated guideline.
Thank you very much about this. And as we will see, the priorities of a country are not necessarily the one of the other one. So what about Uganda? What were the priority areas really that you identified?
Thank you very much, Alexandra. And in Uganda, we looked at the range of recommendations by the WHO 2023 guidance, and we realized that there are quite a number. And I want to say here that when we reviewed, we adopted almost all as priority, except some few. And the exception from the priority list was the issue of children or babies or infants less than 6 months who had lost their parents, for example. And then we were advised in a recommendation to use what we call the wet nursing. And this one, the technical stakeholders in the review were not in for it, and they left that recommendation. And most of the reason was because of our cultural concerns, which would make it difficult to implement. But above all, the relatively high prevalence of HIV among women of reproductive age at the rate of 6.6. So that was left out from the priority list. But we also had other areas where we adopted, but with modification. And this was the use of community health workers in the treatment of acute malnutrition. We understand there is a gap amongst what we call the VHTs, or voluntary health workers, who form the bulk of our community health workers. And there was issues related to supply chain, especially when you are treating, you have to store the supplies and then the knowledge itself. So we said, okay, we can accept this in our guideline, but let's first do a formative assessment to gather views of the stakeholders, especially in the area of readiness, appropriateness, the training needs, and the other implementation concerns, so that we can ably take on the use of community health workers in the treatment of acute malnutrition. And we also made a reference to conducting a stepwise pilot implementation after that, so that we gather lessons and best practices and this especially in normal and high-risk context when you are using the community health workers. But we said, okay, this is okay, but there is another area which came out, and this is the use of ready-to-use erratic food or specially formulated food when a child has moderate acute malnutrition. Previously, this has been mainly about counseling and letting the child go home, but in refugee settings, for example, that's the high-risk context, we had a supplementary feeding program, and this was driven mainly by partners, especially World Food Program. Now here is the recommendation, and we said, okay, we accept this is very good, but how do we do this? So we accepted that why do we accept specially formulated foods for children with moderate acute malnutrition? We are going to consider those with individual risk factors to be given RUTF as the specially formulated food. And the others, we had other options. And then we said when we start implementing this adaptation of use of specially formulated food in terms of RUTF, we should do it in a phased manner, because it would be, we wanted a cautious attempt to make sure that we start off with this use of RUTF to prevent unforeseen circumstances that would disrupt especially the supply chain. Then we also had the multi-sector and multi-system approach, which we thought was another priority, very good, because it was one of the cornerstones for prevention, and that prevention is highlighted very much in the new guidance. But here we wanted to enhance integration of the community health care package, and then engage parasocial workers, health assistants in areas such as water, sanitation and hygiene, among others. So the multi-sector and multi-system component of the priority was a priority among our adaptation of the recommendations. Yeah.
Thank you so much. And yeah, we can see it's really not a one size fits all, and that's the importance of contextualizing the guidelines. Je vais passer en français. I'm going to switch to French avec la Mauritanie. Donc, on n'a pas de diapositive pour ça, mais Dr Mokhtar, je suis sûre que vous avez des réponses à cette question. Quand les guidelines sont sortis en 2023, qu'est-ce qui a été identifié vraiment par votre ministère comme les domaines prioritaires pour mieux lutter contre l'émaciation en Mauritanie? Et pourquoi ces domaines prioritaires-là? Si vous êtes là, docteur Mokhtar.
Oui, je suis là. Merci beaucoup.
Super, merci.
Merci de m'avoir posé cette question. Voilà, nous avons... je peux partager ça avec vous, bien je...
Oui, oui, il n'y a pas besoin juste de nous partager oralement quels étaient vraiment, en ayant écouté en plus vos collègues, quels étaient les éléments prioritaires que vous aviez décidé de prendre en compte quand vous avez commencé le processus.
Très bien. La première, de prioriser les aliments spécialement formulés pour les enfants MAM, c'est-à-dire qui souffrent de la malnutrition aiguë modérée, présentant des facteurs de risque individuels et sociaux, implicites des conseils. Donc, nous avons tenu en compte cette recommandation pour permettre d'identifier de manière proactive ces enfants vulnérables pour la prise en charge renforcée avec ces aliments spécialement formulés, donc en évitant l'aggravation de leurs états vers la malnutrition aiguë sévère. Également, d'impliquer les agents de santé communautaire dans le dépistage et la prise en charge. Pourquoi? Parce que cela améliore l'accès aux services dans les zones reculées et permettre un suivi rapproché des enfants à risque identifiés. Comme vous le savez, la Mauritanie est un pays tellement vaste de 10 millions de mètres carrés de territoire et donc la couverture sanitaire est un peu difficile dans les zones reculées du pays. Également, nous avons pris en compte l'évaluation et la prise en charge des menstruations par les agents de santé des unités de soins de base. Pourquoi nous avons pris en compte cette recommandation? Parce que c'est une mesure essentielle pour décentraliser et améliorer l'accès au dépistage et la prise en charge précoce de la malnutrition, surtout dans les zones que j'ai citées, tantôt les zones également, une détection plus rapide et le suivi de proximité. Nous avons également pris en compte la recommandation, le maire et les titrices d'élèves sont moins de 6 présentant un risque de croissance et de développement médiocre. Ils doivent recevoir des soins et une surveillance régulière par les professionnels de nous avons tenu en compte parce que notre contexte donc, a besoin de renforcer la protection des les plus vulnérables et en garantissant aussi une prise en charge spécialisée immédiate. Et donc, cela va permettre certainement de réduire ainsi la mortalité infantile.
Merci beaucoup. Merci pour ça. Je
Merci.
vais, comme on suit avec d'autres questions, je sais que vous allez pouvoir continuer avec celle-ci. Merci beaucoup de tout ça. Donc, vous voyez bien que chaque pays a des priorités différentes en fonction de leur contexte, en fonction aussi des causes de la malnutrition quand elles sont identifiées. Donc, une autre petite question pour vous, puisque on a vu que vous avez soit tous revu vos guides, soit que vos révisions des guides sont en processus. I will switch back to English. Sometimes I don't realize. Je vais parler en anglais à nouveau. So as we've seen that you all either revised the guideline in your country of intervention or are in the process of it, we are interested to know what were the priorities for your countries when it was identified. Was it, and you'll see on your screen when you go, prevention is hidden by the QR code, but it will be an option for you. So prevention, the management of under 6 months, inpatient, outpatient, supplementation, or other areas as we discussed, for example, post-exit would be one. So just go on Menti again, QR code. I'm gonna share the result and let us know. You'll have the code again if you don't have time. So this is the first one, and this is our next slide. So Menti, the code or the QR code, and let us know. What was viewed as a priority for your country for the revision? I know that everything was revised, but some of them were really a big priority. Okay, it's coming. The QR code is hiding the prevention, but there is prevention behind. So let's see if it goes up. Yes. I think I can actually now remove it. Yes. Yeah, the under 6 months was really a big revolution. It was included in, it was mentioned in the 2015, but without clear instructions. So prevention was very new as well. So yeah. I need a bit more votes. Keep it coming. Okay, but a net preference for, yeah, prevention in another 6 months as being the big priority. Surprised nobody is mentioning the MAM, because also there was quite a lot of difference from before on that component, but it's okay. So you can continue voting anyway, like the vote is not closing as I'm switching back. I'm doing a gymnastic, as you can see today. So I'll continue in English, and I have some more questions that will really highlight some really interesting technical elements, you'll see. So we've seen the priorities. Now, as we discussed, some of the recommendations really had to be adapted to the local context because depending on the way the health system is or the structure of the society is, and we've seen it, for example, for the under 6 months and wet nursing. That was an example for Uganda, but we wanted to go a little bit more in detail on some of the recommendations that really needed to be adapted thoroughly to your local context. So we will hear first from Nepal again. And I need an explanation on the acronym because I didn't know what they meant.
Thank you, Alexandra.
Thank you.
Respecting the principle of infant mother death, inclusion of 𝗵𝗶𝗀𝗃, it means mental health and psychological support.
Yeah.
Component to screen mothers and caretakers. Adding patient health questionnaire 2 and generalized anxiety disorder 𝗪2 screen. Identify the mental health related issues and refer if needed. Out of 9 questions in PSQ2, we use only 2 questions because we did not want to burden the health worker.
Yeah.
So, in regards to RUTF dose, upper limit used 185 kilocalorie per kg per day because according to the WHO new guideline, IMAM guideline, it says there is a range of the calorie per kg per day, 165 to 185. So we adapt or we took the higher range. We took the higher range, that is 185 kilocalorie per kg per day because intra-household sharing between the sibling and family member exists. So gradually shift to lower dose to avoid the shock during the management practice and supply chain. So according to the 𝘂𝗶 survey or the recommendation by the 𝘂𝗶 survey, we do intra-household sharing. We found the intra-household sharing between the sibling and family member.
Yeah,
Yes.
thank you very much. No, that's a very, very good example of how the context changes and makes you making some specific choices. So thank you so much. We'll hear now from team, I think, for Uganda about some of the adaptation they made.
Thank you, Alexandra. This is 𝗃𝗴𝗹𝗁, Uganda, co-working with the team. So among the key adaptations was mother-infant pair, partially less than 6 months, and of course the in-depth assessment. WHO recommended in-depth assessment, partially after triage of the children. So we adopted in-depth assessment as part of the key adaptations across, whether for inpatient or outpatient during at the health facility level, to emphasize a comprehensive assessment for medical, feeding, and psychosocial for both the mother and the caregiver, so that safe, appropriate management of the child was possible and also for the provider to use that as in decision making, whether to manage as outpatient or manage as inpatient, or if the services are not available, to refer to the next level. So for the infant pair mother, we guided, and we have 4 items or levels as far as the infant, so that danger signs or acute medical problems, assessment of nutritional status, breastfeeding problems with the infant or the child, and then also clinical in-depth assessment, or what we are calling in-depth assessment. Similarly, we detailed as far as guidance on the mother, so that the mother's nutritional status is assessed, the breastfeeding difficulties that mothers tend to have, also the clinical assessment, then the psychosocial assessment, mental, and also the general well-being of the mother. And the next schema in the next slide shows based on the WHO guidance, to classify the infants less than 6 months into 4 categories. That if you have a pool of infants less than 6 months, the infants at risk of poor growth and development, specifically that they are those who are born or due to poor birth outcomes, born preterm or low birth weight as one category. Then the other category are those with known risk factors for poor growth and development. And we had a clear definition in the guide, what we mean by neural concerns, or infant with feeding problems or maternal risk, such as mental issues or history of previous hospitalization as one category. Then another category, C, infants who have been measured twice, if particularly say in immunization clinic or outpatient, they have come today, then a month later, measurements have been made serially, and no weight gain, or there is weight loss as by the mother's history, or there is a downward crossing as far as weight for age, in terms of percentiles, as one category C. Then also D, which is infants with a poor anthropometry, who have been measured on a single measure, and they are found to have weight for age or weight for length Z-score less than -2, or nutrition edema, or mark of less than 11 millimeter or 11 centimeters. So that's as the 4 categories. And this is the schema showing that once infants have been categorized in the 4, we would then categorize those who have severe wasting. And in the next schema, in the next slide, it shows that the 4 steps, as you can see, triage, then if emergency, they are supported, and assess nutritional state. And then 3rd step is medical, psychosocial, and feeding problems. So the infants less than 6 months, those with severe wasting, the clinician or the provider would make a decision if they have some and they are admitted as inpatient or as outpatient. Then infants less than 6 months who do not have SAM, they are managed on the general pediatric ward, but in a corner or specialized beds for mothers having infants less than 6 months. Hopefully that is clear based on this schema, so that those who are SAM are the only ones who go to the inpatient therapeutic care, or what we would call ITC, or outpatient therapeutic care. Further, once the feeding aspects have also been assessed, we would identify those with the prospect for maternal breastfeeding and those without prospect for maternal breastfeeding. So we detailed how infants without prospect for maternal breastfeeding would be supported using either infant formula or human donor milk. Cow's milk or animal milk is very much used in the country, but we only put it as a temporary measure since it's not recommended by WHO. In the next slide, we show now about MAM. Management of moderate wasting is another key adaptation we had to work on. And under this, and in line with WHO 2023, the cornerstone in terms of management in the guideline, we emphasize nutrient-dense family food. However, in line with the WHO 2023, two things. One, infants or children with individual risk factor, and then children in high-risk context. So in our guideline, the adaptation was that all the children with MAM and they have individual high-risk factor were to use ready-to-use therapeutic food as a supplement in addition to the nutrient-dense home food, regardless of whether high-risk context or normal context. Then, children with moderate wasting and they are in high-risk context and they do not have individual risk factor, we guided to receive ready-to-use supplementary food. So those are the major adaptations as far as which we could share in this short time. Infants less than 6 months and MAM. Thank you.
Thank you so much. I know you wanted to share so much, and we wanted to hear so much, but unfortunately, we are limited in time. But I think this is also something that will be very useful to people who are currently doing the revision of the guideline in their own country. Though, thanks so much. I will switch back in French. On va passer en français à nouveau. Et donc, je vais demander à Dr Mokhtar, de votre côté, est-ce qu'il y a peut-être parce que je regarde le temps, une des recommandations que vous avez adoptées qui vraiment a dû être modifiée pour s'adapter à votre contexte? Si vous pouvez nous donner un exemple. Docteur Mokhtar, vous êtes à nouveau avec nous? Ou Zakaria? Vous êtes peut-être en silence.
Oui.
Ah, voilà.
Merci beaucoup. Effectivement, nous avons cité la recommandation B13 sur l'utilisation des ASF pour les enfants. Voilà. Le protocole mauritanien a renforcé les critères en exigeant la combinaison d'au moins 3 facteurs de risque, donc au lieu d'un seul comme le suggéré par l'OMS, pour qu'un enfant souffrant de malnutrition soit éligible aux aliments spécifiquement formulés. Voilà, donc cette adaptation permet de cibler plus précisément les enfants et les plus vulnérables dans une ressources limitées. Elle garantit que les ASF également, c'est-à-dire les aliments spécifiquement formulés, sont alloués au cas 1/1000 de risques qui ont le plus grand danger de basculer vers la malnutrition sévère. Voilà notre
Ouais,
recommandation
ouais,
que nous
merci. En effet, effectivement, hein, il y a le contexte, les causes, et puis il y a le contexte, qu'est-ce qu'on fait en cas de ressources limitées, hein. C'est quelque chose dont on va parler, et effectivement, dans ces cas-là, le ciblage est important. Merci beaucoup de partager ça avec nous. Je vais passer, j'avais un autre petit exercice, mais je vais le passer parce que je préfère écouter nos évaluateurs. Si jamais on a le temps à la fin, on le fera. Mais je pense que c'est mieux de les écouter. Donc, on vient de parler justement un petit peu de ça, de la Mauritanie, des ressources limitées. I will switch back in English. Je vais changer en anglais. So we just discussed about sometimes there is limited resources, and sometimes those limited resources are chronic, but there are also some special circumstances in a country, some limited emergencies which can happen due to, yes, shortage, that can happen due to a specific outbreak. It can happen in case of limited human resources, but for a short time for different things, a conflict. So how does the revise, and again, I think a lot can be said, but maybe an example of what was mentioned in your revised national guideline as a special circumstance, and how it was adapted to the time of emergency. So I think Nepal had an example about. Ma'am, if you can tell us a little bit about it.
Thank you for your questions. And current guideline focuses on the MAM management, tailor-based approach, which is divided into high risks and the low risks, depend upon the local level capacity and resources based on the research evidences. We are providing the special formulated food. Yes, provided a special formulated food, not necessary always, but in earlier we used to do the special formulated food. We used to provide the with the support of WFP and the Nepal government. In that time, under 5 children, pregnant women, and lactating mothers, and other vulnerable population as well. According to the now, we will only do this according to the low risk condition and the high risk condition. So in case of low risk condition, we do provided the counseling to have the nutrient dense family foods. We are especially focused for the low risk condition. But in case of high risk, we are focusing on the capacity development of the health workers and at the local community level, and the resources provided some resources to the local level. And in addition to that, we are focusing on the research and generate the evidences. So recently 130 kilocalorie per kg per day need for the MAM cases in case of high risk conditions. So now we refer to use the updated nutrition in emergency guidelines developed by UNICEF, completing the IMAM management. So we will follow in this special circumstances in Nepal.
Thank you very much. Yeah, and indeed, there are different ways of having them integrated or not into the guidelines. So thanks for highlighting that as well. Thank you very much. I think in Uganda as well, I think we wanted to maybe go a little bit deeper on the MAM that you mentioned earlier in special circumstances and high risk context, what you've decided to do. So Ezekiel, maybe?
Thank you very much, Alexandra. So in Uganda is 40% of the population in Uganda, 4% is refugee. Uganda is one of the countries hosting a large population of refugee from South Sudan, from Democratic Republic of Congo, Somalia. Number two, Uganda has a region with chronic food insecurity in the northeastern Uganda, Karamoja. Uganda is also prone to natural disasters, also epidemics and pandemics. These and also seasonal variations in terms of food insecurity in different areas. So in the revision of the guideline, we considered a number of these as part of the context. So we have a detailed guide on such approach as part of the integration across. Then also, as I've already alluded to, on management of moderate wasting in the context of high risk context, we have already explained that children with individual risk factor and they are in emergencies or special circumstance, they receive ready to use or RUTF as the supplementary food if they have individual risk factor, such as if the middle palm circumference is between 11.5, 11.9, or weight for age is less than -3, among others. Then children who have MAM in a high-risk context and they don't have individual risk factor, that is the last box, we guided to receive ready-to-use supplementary food. And this was also based on that RUTF is widely available or supported by UNICEF, but also by the government in terms of match funding. So RUTF across the board is both government and partners in terms of match funding is easily available across. That's why we based on that to use to guide the use of RUTF. Whereas RUSSF, 𝗂𝗵𝗄 blend, and others for children in high-risk context when they don't have individual risk factor, and a lot of support comes from WFP. And all of these decisions were made between the government and UN agencies, UNICEF and WFP and others, UNHCR and so on. Thank you.
Thank you very much for that. And so I will switch back again to French. Je vais passer en français. De votre côté, Dr Mokhtar, vous avez inclus aussi une section sur les circonstances particulières dans votre guide? Et peut-être nous parler peut-être une d'entre elles que vous aimeriez partager ou vous avez dû adapter et dire, bon, en cas de cette circonstance, dans ces cas-là, eh bien, on adapte la recommandation et on fait plutôt ça.
Merci beaucoup. Merci pour la question. En matière d'urgence, le protocole révisé a notamment abordé les urgences et les aspects en matière des urgences, a abordé les déclencheurs. Une urgence est déclarée en cas de prévalence de malnutrition aiguë supérieure à 15%, opération de centre de santé ou rupture de stock, épidémie ou crise alimentaire aiguë. Nous avons également adopté les stratégies de réponse, de faire le dépistage de masse active pour identifier rapidement les cas, adaptation du protocole également, simplification des critères d'admission et réduction de ration des aliments thérapeutiques, si nécessaire pour faire face aux afflux de patients. Donc également, distribution ciblée de nourriture et de cash aux populations vulnérables. Ceci également un processus continu selon l'adaptation aux saisons. La coordination également renforcée, activation de mécanismes de coordination dirigés ici chez nous par le commissariat de la sécurité à la sécurité alimentaire, mais également soutenu par le ministère de la Santé et les partenaires techniques et financiers. Nous avons également l'approche de renforcement des capacités de centre pour gérer l'afflux soudain des cas grâce à la planification préventive des seuils d'alerte. Voilà, donc, en bref, notre protocole prévoit une réponse rapide, simplifiée et coordonnée pour maintenir les services nutritionnels vitaux pendant toute crise. Je vous remercie.
Merci beaucoup pour ça. Donc, on va terminer avec la dernière question sur le What's Next. Je vais repasser en anglais. I will switch back to English. So last question is, now we have the guideline. The 3 countries have a revised guideline. So now what are the next steps for implementing it in the health system? I will ask you to be concise so that we have a little bit of time for questions. So Nepal, what are your next steps in 2 minutes?
Yes, we have National IMAM guideline endorsed. As we know, we do have the federal structure, all 3 types of independent bodies, and we plan to reaching the most affected beneficiary in the community. We are preparing the standard operating procedure for the local level being developed with the ACF and ECF, 𝗀𝗃𝗃 Foundation, and the training packages updated and reflecting new changes with inclusion of the simple to understandable, as we say, easy to use job ads. And at the last, in Nepal, we do have the multi-sectoral nutrition plan, where the 7 ministries are owned here. So we do have the good collaboration within the stakeholder, and we envision to advocate the incorporated the indicators of mainstreaming with updated guideline. Example, facility-based integrated manager of nutrition and comprehensive facility-based IMNCI and the community-based IMNCI, maternal and mental health. So the capacity building of the health workers and family community health volunteer in cascaded hybrid model, and provide services to those in need.
Thank you very much. Very
Yes.
good. Thank you. Very good, Rob.
And yeah, just a second. In addition to that, now we are practicing the family work as well. So the standard protocol, we are making with the support of, as I earlier mentioned, ACF Nepal and 𝗀𝗃𝗃 Foundation for the local level, and the clinical protocol developed by the UNICEF Nepal.
Thank you so much.
Yeah.
Uganda, next steps in 2 minutes.
Thank you. Uganda, right from inception, we had 3 deliverables: guideline review, the revision alongside the training package for community outpatient, inpatient, and also the enabling environment in terms of coordination and the data. All these have already been completed. We've already done national and regional training of trainers. We've already tested the training toolkit, and the training is quite expensive. And an effort to support country continued professional development, whether pre-service or in service. We've developed an online training and mentorship system. We've uploaded all the training packages from community outpatient to inpatient across all the different modules with an online web-based training system in which the participant, and that's the one, in which the participant is able to pace himself or herself. Then they come for 5-day practical training skills and also clearing issues that are difficult to understand. Next, we've also developed an action plan, a 5-year action plan, aligning to the new guideline revisions. In addition, given the new changes, we've also developed an implementation research protocol to guide adaptation through the 5-year, through the institutional review boards as well, to understand community treatment by community health workers, the new changes of MAM, and also family-led work, among others. Over. Thank you.
Thank you very much. That was great. Je vais revenir en français. I will go back to French. Pour la Mauritanie, alors, quelles sont les prochaines étapes pour vous? Le guide a été revu en août. Où on en est de l'implémentation? Quel est le plan?
Merci beaucoup. Merci beaucoup pour la question. À notre niveau, en Mauritanie, vu notre état d'avancement actuel du protocole, nous avons jugé pertinent de procéder à 3 étapes essentielles. La première, 3 prochaines étapes essentielles. La première étape, c'est de faire pour la mobilisation des ressources. C'est-à-dire organiser une table ronde avec le partenaire technique et financier pour la mise à l'échelle de ce nouveau protocole à l'échelle nationale. Également, organiser une formation de prestataires, c'est-à-dire une série de cascades de formation à tous les niveaux de pyramide sanitaire. Ceci doit être immédiatement, donc c'est-à-dire les infirmiers, les agents de santé communautaire, donc sur les nouvelles directives, protocoles de prévention et de prise. La troisième étape, c'est de renforcer le suivi et l'évaluation de la mise en œuvre de ce nouveau directif. Et
Merci beaucoup. Merci beaucoup pour ça. On va laisser un petit peu de la place à des questions. Je vais repasser en anglais. I will go back to English for the question, but happy to help as well if there are some issues with French with the questions. We have a little bit of time for questions. We also have some really good panelists. So I think I've seen that they were answering to the question in the chat. That's how good they are. But are there some key questions, maybe, Adunia?
Yes, there are some questions. Some of them have been answered, but I think to give a chance to the speakers, to the panelists, we can still, go through those questions. So the first question was from Philip James. Thanks, Mr. Lila, for the information. How did the coverage survey and other research you mentioned influence which WHO recommendations you adopted or adapted in your national guideline? So basically, it is how the survey and the research is influencing the recommendations and the
That's from
adaptations.
Nepal. Yeah,
Yes.
for Lila. I know. Yeah, go ahead.
Yes, we have already answered. The SLIC assessment revealed the high coverage in rural areas, but low coverage in the urban setting. That is one reason. So also the surveys different surveys highlighted that the first contact points were often traditional healer and the private clinics, and referral from them were largely missing. So we included clearly recommendations on the community engagement and the referral pathways, orienting the local actors, health workers, and the private providers to identify and refer malnourished children, and integrating them into the formal IMAM program. So also we found the several components. Indeed, integration in IMAM like 𝗂𝗵𝗶𝗀𝗄𝗃, as I earlier mentioned, facility-based IMCI, and the MSPSS requiring in the updated guidelines.
Okay. The second question is from Astrid for colleagues in Mauritania. How did you deal with the fact that the WHO guideline was only available in English? Were there any sections that were more or less difficult to understand due to this? Can you give us an example?
Oui, docteur Mokhtar, vous avez entendu pour la Mauritanie la question, très bonne question, le fait que les guidelines étaient en anglais. Est-ce que ça vous a posé des problèmes spécifiques de compréhension, notamment sur certaines parties?
Merci beaucoup pour cette question pertinente. Ici, en Mauritanie, la langue principale du pays, de la majorité de la population, c'est la langue arabe. La majorité de personnes de santé, on va dire. Donc, le problème posé par l'anglais est le même problème pratiquement posé par le français. Cependant, nous adaptons toujours à ça et on fait recours à la traduction. Nous avons traduit notre document final. Nous avons préparé le document en français, la revue en français, mais nous avons le traduit en arabe et nous avons multiplié ça en arabe, Inch'Allah, pour la mise en œuvre.
Merci beaucoup. C'est une très bonne question. Peut-être une dernière question à Dounia, peut-être pour Ouganda? Dounia, sorry, I'm speaking to you in French, but you know you need to learn French, Dounia. So that's why I'm speaking to you in French. Is there a question for maybe Uganda? Last question for Uganda.
Yes, for Uganda. Okay, it's for Dr. Tim. The question is related to the level of wasting. We know the prevalence rate of wasting is low nationally. Are there geographic disparities with districts having high levels of wasting? Example, in districts where we have a high refugee population and places such as Karamoja, which is drought prone, how do the guidelines accommodate these places in light of developing a national guideline?
Yes, thank you very much for that question. While we were developing this guideline, we were cognizant of the context in which we are going to operate. And as you may have heard from Dr. Ezekiel, we have categorized this country into risk contexts. And we know that the refugee host districts and the refugees settlements are actually the high-risk contexts. And we also have a region we call Karamoja, which is a food insecure, kind of chronic food insecure region. And our biggest concern while we were developing the guideline was that it was better to look at prevention approaches and especially the use of family-led work, the use of VHTs to make sure that there's early identification. And these ones, as we speak, are supposed to be strengthened, starting with these in these areas which are high-risk contexts. So we already know so that we can have early identification, and referrals. We also have the multi-sectoral approach, and these are the areas where we have most of the partner support located. And therefore, we are aware of the situation on the ground, and therefore, our multi-sectoral and multi-system approaches that are very high in the guideline are strengthened, but priority is to start with those high-risk areas. Not to say that the other areas do not matter, but when we come to also another area of MAM, management of acute malnutrition, we again contextualize the country in areas which doesn't have high-risk context. Children who have moderate acute malnutrition and without individual risk factors have been accorded the use of family-led. I mean, we use the family foods, which are rich, nutrient-dense family foods. So we categorize the country based on the contexts, and starting from what we would call normal, if you put quotes on it, and then the high-risk context, and we are aware of that while we're developing this guideline. Thank you.
Thank you so much, team. Thank you so much to all our panelists. You were really, really, really great. You taught us a lot, I think, in such a short period of time. We will answer to the other question when we will share the PowerPoint, so don't worry if your question was not answered. I wanted to remind all of you that next week, on the 4th of December, if you want to enrich your knowledge on acute malnutrition, there is a research for nutrition conference in Paris. It's hybrid, so if you cannot be there in person, and if you are, I'll be really happy to see you there. But if you're not, you can register online. So maybe we can put, Adunia, maybe you can put the link in the chat to register. But if you Google research for nutrition 2025, it will appear. Don't leave us without answering the survey that will pop up. We want to remind you and really, really thank the Global Nutrition Cluster for their help on organizing the webinar today. Also thanking the Eleanor Crook Foundation for the project and for the sponsoring of this webinar. Remember that the GNC can give you many types of support, remote, in-country, hiring a consultant, quick technical advice, or peer support through the ENET forum. You can request your support on the website or scan the QR code that you see on the screen. It's here when you go on the GNC website, request support. And once again, please fill out the webinar evaluation, and thank you so much for being here and listening to our great panelists. See you soon.